القصر العيني على المجهود اللي باذلينه في المؤتمر السنه دي، يعني الحقيقه من الورك شوب للمحاضرات اللي باديه بدايه قويه. لظروف صحيه الحقيقه دكتور كاسبريني هيبقى معانا اونلاين، ما قدرش يجي فيزيكالي، فهنبدا بالاستاذ الدكتور ايمن فرغلي هيكلمنا على year in practical review of interventional pulmonology.
Assalamu alaikum wa rahmatullah. Actually, it's my pleasure to be here among the distinguished faculty, and I would like to thank Professor Tariq and Professor Ahmed and all the organizing committee actually for the kind invitation. Here in practical review, actually, Professor Halafawi has helped me to choose this topic, and actually it's gonna be some sort of snapshots of practical applications that we are using every day. So these are the center that I'm working with, the Air Force Specialized Hospital, the International Medical Center. During this year, we have around 530 bronchoscopies, 56 of them are rigid, 56 thoracoscopies, and 52 right heart cath. And this is the unit. Actually, this is our unit in the International Medical Center. So I will start with foreign body removal, which is usually very annoying and very urgent, and actually it constitutes a medical emergency for us. And our approach is using the laryngeal mask and fibroscopes. We abandon using the rigid scope, and this is the approach that we use, and we take the basket, different sizes of basket, and we trap any kind of foreign body. And actually, sometimes we have in neonates, we can do it, and it's very easy to handle the foreign body safely. Different kind of foreign bodies we have, and as you see here, we have the basket. Any kind of foreign body you can imagine we have during this year. And this is a kind of illustration how we can trace a foreign body like this. This is a needle which is almost under the diaphragm. So we started to look for it by the ultrathin bronchoscope. You can see that we delve it through maybe the 10th or 11th generations in order to find this needle, because the other solution would be to send the patient to the surgeon. So we don't like to send patients to surgeons. So we kept looking for the foreign body. Actually, it was very tedious. We spent maybe half an hour looking for the needle. Sorry. I will go rapidly for a while. Oh. It's not working. We reach it to the needle, and you can see the needle very far away. Even the forceps, 1.2 millimeter forceps, we cannot open inside. So we went with the basket. And actually the mesh here is the tip of the needle, and the mesh could trap it very well. And you can see how firm the grip for the needle. Sometimes these needles are very hard to bring, and we need the rigid scope in order to reach it and grasp it very well. I have my assistant. I tell him to tight the grip, and then we pull it out. You will see it now. So we have it, and you can see how strong the grip. So the nurse is trying to remove it. It's very hard. So I think this is our preferred method now, and we have a lot of foreign bodies taken out like this. Benign tracheal stenosis, actually, when I see it, like my colleagues do, we go to surgery. However, when we go to another solution, usually dilatation is the best. And this is a dilator that we have, the Groningen, and we have two sizes, the smaller and the bigger size. But now we are doing the balloon, and actually the balloon is a preferred method for us, and actually successful in many cases. And as you see, we inject water in the balloon. It's a long balloon, 6 centimeters, and this is a case. It shows a long segment. It was not amenable for surgery. عايز اوقف الصوت لكن anyhow انا كنت ميوتنج الصوت بس مفيش فايده. We introduce the balloon along a guide wire through the laryngeal mask, and then we use I think this is going to be much better. Okay. After the balloon is in place, we inject water or saline inside, as you see here, and we have a pressure tracer, so we know the size of the balloon according to the pressure, and we adjust it for maybe 20 to 40 seconds, and release it for aeration, and then we can repeat it again after that for 2 or 3 times, to be repeated after 2 or 3 weeks, and then after 1 month. And actually, it is one of the successful methods, and sometimes we inject mitomycin if we find it. Stenting the airways, and actually the kind of stents that I usually do is a hybrid stent in different airways. And also we use the dynamic stent sometimes. I have 5 cases with the dynamic stent, and we have to bring it from abroad. And also the Tumor stents. And actually, when I have a lesion near to the carina, I prefer to use the Y stent because it is fixed very well, and we can modulate it according to the situation and length we need in both main bronchi. The gledoscope sometimes facilitates our approach directly through the vocal cords. We can introduce it through the bronchoscope, whether the fiber optic scope, or through the Freytage forceps. We can introduce it directly by the Freytage forceps inside. And this is one kind of a patient who has right side tumor, and we have this stent beautifully here in the lower trachea and both bronchi, and it lasted for 4 years, and I'm trying to tell him that I have to remove it because he has a successful treatment. He is rejecting to remove, he is afraid to remove the stent, and he is doing well, actually. So this is a case with tracheoesophageal fistula, as you see, huge fistula, and we applied the hybrid stent, and unfortunately it was not lasting because the patient could cough it easily. Then we went through the frottage forceps.
The forceps down into the trachea.
And this is to illustrate how we introduce it through the vocal cords directly. And then we upload it there. Then we go with the rigid scope. We go with a rigid scope because we have to align it properly using the forceps, the rigid forceps, as you see here. So when we reach it, we move it and put the rings, the rings in the anterior, and we have the malleable posterior part of the esophagus. And this is the last picture. We have to align both limbs very well along the right and the main bronchi, as you see here. Unfortunately, the tracheal tear has been elongated. That's why we introduced the covered stent over the dynamic stent. So we can cover the whole length of the trachea. This situation remained for 6 months. The patient was taking radiotherapy, and unfortunately, he died later due to complication. But of course, the gastroenterologists were trying to put a stent in the esophagus, but they failed because it was so tight and there were strictures from the tumor. It was a lymphoma in the esophagus. So this is how we deal. We can sometimes use what we have. We have post stents, so we remove it and we introduce it again and so on. These are the vocal cord polyps, and actually I don't like to play with the cords. However, I have the ENT colleagues sending me patients, and it is difficult for them to approach. So they said, can you try to do it? And actually, we have chosen to play it with the cold approach, the cryo. So I started to play with the mass because it looks very vascular, and I need to know what's going to happen. And by the way, the ENT consultant was by me, and the tracheostomy was ready also. So the process was very, very, very enjoyable, actually, and I told them to bring me more of these cases. And when I revised the literature, I found that ENT, they don't use the cryo. I don't know why. And in the literature, I found only 2 or 3 cases. And they were in India using the cryo probe in order to remove vocal cord polyps like this. I freeze, طبعا دكتورة صباح عارفة الكلام ده كويس. I freeze before I remove in order to coagulate the blood vessels and to be sure that I'm not going to cause a major bleeding. And this is a situation after we remove. For the sake of time, I'm going fast, I'm sorry. It was removed over four trials, and this was the final picture, and the ENT consultant actually was happy with that. Transbronchial cryobiopsy, actually, we were using it very much maybe 4 or 5 years ago, but now with the more experience with the CT, we don't do it. However, sometimes we do it, and actually, we use it with a blocker. I use the blocker in order to guard against the massive hemoptysis that sometimes happen. Although I didn't have any case of fatality or mortality due to hemoptysis, even when I start to use without the blocker, we introduce it through the laryngeal mask, and we put the blocker ready. As you see, this is the blocker, and then the cryoprobe is, we are choosing the segmental bronchus that we are going to biopsy, and then we fix it, as you see, for 3 or 4 seconds until we are happy that we have a biopsy. Of course, we use a fluoroscopy sometimes in order to be assured that we are not touching the pleura. After we remove the cryoprobe, we inflate the balloon, as you see, in order to be sure that there is no, and tamponate any blood that might come out. And this is the final picture. Actually, it is a very easy and good procedure. Sometimes we have pneumothorax. I have maybe 2 or 3 cases of pneumothorax, and one of them necessitated using doing intercostal tube. This is a conventional method, and actually we don't use it nowadays. And this is Hatem. I was helping him in order to take thoracoscopic lung biopsy. We have a lot of cases we have done before, but nowadays we don't use this method. In fact, we go with we dissect the pleura, the thoracic wall, until we induce pneumothorax, and then we're using the forceps with the electrocautery. We choose the area of lung that we are going to biopsy and hold it up until it gets down alone. So we take the biopsy out, and this is a bunch of biopsies that we have. Actually, it's a very good bunch, and it is very easy procedure. However, it is more traumatic than the other one, and usually we do it under local anesthesia with light sedation. In some cases, I'm not obliged to put a chest tube. I just suck the air, but I have to be sure that there is no air leak. So push saline over the wound, as you see here. This is the wound we left on the lung. So we push saline in order to see that there is no bubbling. Then we close the wound, and that's all. Anyhow, the transbronchial cryo actually is more easier, and I think less traumatic than. Actually, EBUS, when I start to look the era before the EBUS and how we were doing with our patient, actually EBUS is one of the most important and actually very helpful procedures that we have nowadays. Because I remember when we go inside the airways and we found nothing, and we know there is a tumor that is compressing from outside, it is there, but we cannot reach it. And the other options are surgical. So I believe EBUS is one of the most important, and actually we are trying to apply ROSE. We have 10 cases now done with ROSE. We do a lot of EBUS. Actually, we started to have some more experience. Of course, we are building our experience, but it is very helpful, and our diagnostic yield is approaching 90%, which I don't think it's bad in most of the cases. Sarcoidosis, actually, it is doing very good job with sarcoidosis, and I usually do transbronchial lung biopsy at the same time with the EBUS transbronchial needle, and we compare the data, and actually it is maybe superior also. As you know, the idea is to know the anatomy by sonar and to know our approach. Usually we use a systematic approach, so we go with the L4, 7, L10, and then we go to L4 and R4, R10. This is the usual. Then we decide which lymph node that we are going to take, because when staging, we have to avoid contamination. So I go to the farthest. So I go to the lymph node that's going to bring me N3. So this is a decision that must be taken even before we go to the laparoscopy, endoscopy suite. So in sarcoidosis and cases of bilateral symmetrical lymph nodes, you don't have to do this. So you can choose big lymph nodes and take biopsy. And as you see, it's very safe, and we are always enthusiastic to have cell block, because nowadays they know that in the era of targeted therapy, they need to do the immunohistochemistry and maybe next generation sequencing and so on. So we try as hard as we can to take a good biopsy. A thoracoscopy, this is my favorite procedure, and actually when we have a pleural oxidate, the thoracoscopy is the way that we use. And I used to do it in primary spontaneous pneumothorax since a long time, and I believe it is very informative to do it in primary spontaneous pneumothorax. You have already the wound, you are going to introduce a chest tube for the patient. Why don't you look and see what's going on if you have the thoracoscope? This is one of the famous cases that we have. It's a malignant melanoma, and as you see, it's the visceral and parietal pleura are seeded with dark lesions, as you see. Sometimes this is a picture of mesothelioma, typical picture of mesothelioma, grape-like appearance like this. The biopsy is very easy. I don't know if the cryo is different. I don't do cryo, actually, a lot of cryo during thoracoscopy. But I think when I have a lesion, I can see it, I can take the biopsy. If I don't, I peel the pleura, as you said, and I might have the diagnosis. But anyhow, it's a very good question that you gave us, Dr. Sabah, about the deeper biopsy. And this is the appearance that might come when you have pleural polyps, something you cannot predict. When you find the pleura embedded like this, the visceral pleura and the lung is full of polyps on the surface. And this can give you an idea this patient is going to have pneumothorax in the future. And this is one of the cases of primary spontaneous pneumothorax. You have here bulli, huge bulla, and this is a case of lamb. This girl came to us presenting with bilateral pneumothorax, and there was no room and no time to go to the CT even, so we have the thoracoscopic picture as you see here. The whole lung is full of polyps and bulli in the whole area. Bronchoscopic lung volume reduction, and actually we cannot cope with the umbrellas and the other valves, so we have to go with our local what we have. And actually we started our program for histoacryl maybe 6 or 7 years. It was Hatem idea actually, who gave me this idea, and it was his MD thesis later on. We have done maybe 40 cases as far as I remember. Then it is in regular use now, and I use it when I have a homogeneous emphysema and I have to do a VQ scan in order to know that the area that I'm going to block is going to be not contributing a lot to the lung perfusion. So I do routinely VQ scan before I do lung volume reduction. And actually this is one of the cases. We go and determine properly the place. We don't care about collateral circulation. In this case, we just obstruct the lobe. We have to suck the secretions very well, because we don't like to block over the secretion, because this is one of the most important complications that you might lead to infection and maybe lung abscess if it is entrapped inside. So we go and decide. This is the left upper lobe. It was our target here. And then I will go a little bit rapid. So we have the caster inside. Sometimes I use the caster of the gastroenterologists. They use it in their work. Sometimes I use it because it is wide channel and more. And sometimes I use the Swan gans. And I use the advantage of the Swan gans. It has a balloon. So I inject and inflate the balloon. So I trap the fluid inside, not to be drilling through the whole lung. This is what we do here. And this is a picture after we do. So we have inflammation, and sometimes we have some accumulation of the histoacryl, as you see here in the upper lobe. This is a bilateral case. Usually I do it after 2 weeks. I do the first case, and if it is successful, I do it in the next side. This is one of the successful cases, and as you see here, starting to be scared. There is scars and fibrosis and collapse. And this is our target from the procedure. This is, actually, I do it, few cases we do with the pulley. I don't like to play with the pulley unless the surgeon say that I cannot do it. And this, a pregnant lady, actually it was the first case we do. She was a pregnant Sudanese lady, and the surgeon refused to do it. And we do it with histoacryl. And actually here you can see there is some inflation in the right lower lobe, and she can travel And she didn't come, but she is telephoning me. Maybe now, Hatem, 7 years maybe. Of course, we are trying to show our work and the publications, and we join, the universities, our colleagues and professors, in order to show the work and also to learn from them and join our work, because I believe this is our mainstay of treatment. If you consider the right heart cath as a interventional pulmonology, I think we have to add it, because people working with pulmonary hypertension are pulmoradiologists or radio. Okay, this is actually my final case, just to show you our joint activities and our publication with the colleagues. Thank you very much.
شكرا لحضرتك طبعا على الريفيو الرائعه والحالات الجميله جدا. واز يوجوال بروفيسور ايمن دائما ابدا كلنا بنستفاد من خبره حضرتك. شكرا لحضرتك. هو ما عندناش وقت للاسئله بس لان بروفيسور سبينيو دوت اونلاين، فطبعا with my honor to introduce بروفيسور ستيفاني سبينيو اللي هو head of respiratory unit internal medicine department Italy, to talk about EBUS transbronchial lung biopsy, not only the mediastinum. شكرا. طبعا احب اشكر استاذنا استاذ الدكتور طارق صفوت، استاذ الدكتور اشرف حاتم، استاذ الدكتور احمد الحنفاوي على الدعوه الكريمه لحضور المؤتمر.
Hello, good morning. Can you hear me? Can you hear me? Can you hear me?
No, Dr. Stefano, we cannot hear you.
Can you hear me?
Yes, we can hear you.
Yes.
Okay. Can you hear me?
Yes, we can start.
Okay, we can start. So, first of all, I would like to thank Dr. Hamed for this kind invitation. I'm very sorry to be unable to be there, but unfortunately, I'm COVID positive. It's unbelievable. I survived, and the last 2 years, I did a lot of bronchoscopy in COVID patients, and I didn't get the virus. But my wife was positive, and so I get the virus just in these days. So I'm fine, but I cannot travel. So my first talk will be about EBUS TBNA, not only mediastinum. Well, this is my conflict of interest disclosure. Well, you know, this is the history of interventional pulmonology. In the history of interventional pulmonology, there are 2 main steps that introduced and changed the life of interventional pulmonology. The first one was the introduction of flexible bronchoscopy, of course. And the second most important innovation, technological innovation, was the advent in 2005 of the EBUS TBNA. That changed completely the life and the practice of our procedures. These are the pioneers that published the first paper on EBUS TBNA. You can see Mark Krasnick in 2005, Casimiro Yasufuku, and Felix Sert in 2006. And for since the first paper, it appears evident that EBUS TBNA was a procedure with a great sensitivity, 94%, regardless lymph node location or sites, and a specificity of 100%. According to these results, EBUS TBNA became the major procedure and the first step procedure for the staging of lung cancer. And the staging of lung cancer was the first application of EBUS TBNA. But in the following years, we realized that EBUS TBNA is not important only for lymph node staging and diagnosis, but with this technique, we can also sample pulmonary lesion adjacent to the airways, pleural lesion adjacent to the mediastinum. We can diagnose an endovascular lesion, and the interventional pulmonology learned to go through the esophagus with the echobronchoscope. And this increased our diagnostic possibility because we were able to sample also paraesophageal, pulmonary, or pleural lesion, but not only thorax lesion, but we were able to go behind the thorax and to sample also left adrenal gland and liver metastases. Well, I would like to show you some cases, some practical cases of our experience to demonstrate these possibilities. You can see lesion adjacent to the major airway. This is a lesion adjacent to the trachea. You can see how it's easy to visualize this pulmonary lesion through the trachea and to sample the lesion with the TBNA under ultrasound guide. And it was an adenocarcinoma, an squamous cell carcinoma, sorry. The second case, again, is a lesion adjacent to the right main bronchus, 1 centimeter. And you can see how it's easily visualized using our echobronchoscope, and how it's very easy to sample this lesion using the EBUS TBNA. In this case, it was an adenocarcinoma. The third case, again, a lesion very close to the right main bronchus. You can see here the sampling using EBUS TBNA, and it was, in this case, fortunately, an hematoma. But we can go also more peripherally, not only for lesion adjacent to the right or left main bronchus, but we can also sample lesion, like in this case, adjacent to the left upper lobe bronchus. We can wedge the bronchoscope in the left airway bronchus, and we can see easily the pulmonary artery here, and you can see here the pulmonary artery with the Doppler, and the lesion that was sampled, and again, it was an adenocarcinoma. But we can go also more peripherally. We can wedge the echobronchoscope in the middle lobe, for instance, to visualize this peripheral lesion. And you can see here the lesion, very well visualized, and we can safely sample this lesion. You can see here the fluoroscopic view and the echobronchoscope very close to the this mass or nodule. Again, another case of lesion in the middle lobe. And you can see the visualization using EBUS scope, and the echobronchoscope inserted into the middle lobe and the needle into the mass. Again, an adenocarcinoma. Most of these cases are adenocarcinoma. We are going on more peripherally. This is a very interesting technique that is not very well known by a lot of colleagues. If you have a peripheral lesion in the lower lobes, you can wedge the scope peripherally, and you can see this small lesion in the left lower lobe. There is a bronchus. If there is a bronchus adjacent to the lesion greater or equal to 5 millimeters, we can insert the tip of the echobronchoscope in this small bronchus, and you can see how it's easy to visualize the lesion that in this case was a carcinoid. But smaller lesion, this is a 8 millimeter nodule in the right lower lobe, but there is a bronchus 5 millimeter very close to this lesion. Well, bending the tip of the scope, wedging the tip of the scope and bending the tip of the scope, we can move this bronchus toward the lesion, and you can see how a lesion of 8 millimeter is easily visualized using EBUS scope, and it was easy to sample this lesion that was a metastasis of urothelial cancer. Again, another small nodule with a large artery branch very close, but there is a bronchus 5 millimeter here, and we can see the artery, we can see the nodule, wedging the tip of the scope in the lower lobe segmentus and sampling easily this small nodule without risk of damage or puncture the artery. It was again an adenocarcinoma. This is a lesion of the left lower lobe. Again, you can see here a bronchus greater than 5 millimeter, and you can see here the lesion, and the diagnosis in this case was carcinoid. Smaller lesion, left lower lobe, again, you can wedge the tip of the scope in the left lower lobe. You can go very peripherally with the echobronchoscope, and you can see here the sample of this lesion that again was an adenocarcinoma. So don't forget this technique. Even for small nodule located in the lower lobes. This was a young patient with a history of melanoma with this small nodule less than 1 centimeter in the right lower lobe. You can see here the echobronchoscope and the sampling. So don't forget, and it was a metastasis of melanoma, unfortunately. And this is another lesion very close to the diaphragm in the left lower lobe, very close to a bulla. So high risk for percutaneous needle aspiration, but we can arrive up to this area with the echobronchoscope, as you can see here, and you can safely sample the lesion that in this case was again an adenocarcinoma. So don't forget this technique if you have a peripheral nodule in the left lower lobe. And this is Galileo Galilei, that concerning the moon and the earth said in 50,064, and yet it moves. The trachea, even if it's not in close contact with the lesion, you can see here there is 1 centimeter, the trachea is not fixed in the thorax and can be moved by pushing the tip of the scope toward the lesion. And you can reach lesion even if the lesions are not in contact with the airways, like in this case. You can see here, the tip of the scope is bended, the trachea is moved to the lesion, and you can very easily visualize the lesion, even if the lesion is not closely adjacent to the airway. The esophagus. The esophagus is a supper highway through the thorax and is a new, relatively new way for interventional pulmonology. It's very easy to go with the echobronchoscope through the esophagus. The procedure is better tolerated by the patient. There is no cough, there are no cartilage. So it's very easy to approach also lymph node like station 8 and 9 that are not in contact with the airways, so to complete the staging through the esophagus. And we can also sample liver metastasis and left adrenal gland metastasis. And we wrote an editorial on respiration because for the first time, the bronchoscope is able to go behind the thorax. And we can see some cases. This is a lesion, a nodule of the left lower lobe, very peripherally. You can see here the diaphragm, but it's close to the esophagus and very easily visualized through the esophagus. And it's possible to sample this nodule. Again, also the esophagus can be moved. And if you have a lesion that is close but not adjacent to the esophagus, you can move the esophagus, bending the tip of your echobronchoscope and bringing the tip of your echobronchoscope very close to the lesion that can be easily visualized like this case. And this is another mass of the left upper lobe and very close to the esophagus and very easily visualized through the esophagus and was possible to sample. So don't forget the esophagus. That is really an alternative for our approach. Again, here is a mass of the right upper lobe, and you can see how it's easy to visualize this mass through that is adjacent to the esophagus, through the esophagus. Look at this pleural lesion. Also, the pleural lesion are important. This is a patient that 2 years before underwent right upper lobe lobectomy for adenocarcinoma, and in the follow-up, this pleural plaque or thickening was observed that was PET positive. Well, the esophagus is here, and the lesion is very close to the esophagus, and you can see here the ESSB FNA through the esophagus of this pleural thickening that unfortunately was a relapse of the disease and was a location of adenocarcinoma. Well, pleural lesions. This is a pleural masses, pleural thickening, again, very close to the esophagus. This was intensively PET positive, and you can see here how we can visualize the pleural mass through the esophagus and perform sampling with the needle very safely and very easily. And in this case, the diagnosis was mesothelioma. Left adrenal gland. This is the classical image that we can obtain with our echobronchoscope of the left adrenal gland. Is like a bird. This is the normal left adrenal gland, and this is a metastasis of the left adrenal gland. So you can imagine how this could be important for staging lung cancer if you have a lesion that is PET positive in the left adrenal gland, is easily visualized. Also, endovascular lesion can be approached, and the differential diagnosis between endovascular tumor like sarcoma or bronchial artery embolism has been described in the literature, and the pulmonary embolism, like in this case, are very easily visualized using EBUS bronchoscope. You can see with the Doppler the vessel, the blood, and the thrombus, the embolus inside the vessel. And What about the possibility of EBUS TBNA to obtain enough material for genotyping the tumor? There are a lot of papers in the literature that demonstrates that the material that we can get from EBUS TBNA is suitable for mutation analysis or for genotyping, also for the evaluation of PD-L1 expression in lung cancer. So there is no problem with the material that can be used in two different ways. We routinely use the smeared cytology, and on the smeared cytology we can do ROSE, we can do immunocytochemistry, we can define the histotype with the immunohistochemistry, and we can also use the material for molecular evaluation. But we use also core biopsy or cell block, and you can see here how much material can be obtained for cell block in with one single pass of the needle. And pathologists are very happy in our institution for this material. They can do a lot of things, and also PD-L1 definition. Well, so the conclusion are that the EBUS TBNA changed our diagnostic approach, greatly increasing the sampling possibility of bronchoscopy. Is for sure a very, very important means for lung cancer staging, but is an invaluable instrument for diagnosis of several pathological conditions involving not only lymph nodes, not only mediastinum, but also other structures close to the airways and to the esophagus. Of course, the correct management of sample is a necessary requirement to optimize the results. This is my town, Ancona, is located in the middle coast of the Adriatic coast of Italy, where the coast make an elbow, and Ancon from ancient Greek mean elbow. This is my hospital. I thank you very much for your attention.
Thank you very much, Prof. Gasparini, for your very interesting talk. And we miss your physical presence with us, and hope you and wish for you a very rapid recovery. I have the pleasure to introduce your second talk, ultrasound bronchoscope in the diagnosis of peripheral pulmonary lesion.
Yes, okay. Let me start with the second talk. That is about ultrateam bronchoscope, the use of ultrateam bronchoscope in the diagnosis of peripheral lesion. Well, so again, my conflict of interest disclosure. What do we know about the transbronchial approach to peripheral pulmonary nodules? The background and the history start a lot of years ago. In 1967, you can see here, this is the first paper published by the team of Ikeda, of Shigeto Ikeda, that demonstrated it was possible to approach under fluoroscopic guidance peripheral nodule to the bronchoscope. They used the curette as sampling instruments. So the first point is that for the transbronchial approach to peripheral pulmonary lesion, a guidance system is required, because we have a very low sensitivity of blind samples or of bronchoalveolar lavage. Less than 5% is the sensitivity of bronchoalveolar lavage in case of peripheral tumors. So unfortunately, I don't know in Egypt, but in Italy, a lot of people still use bronchoalveolar lavage when they have a peripheral lesion. And my suggestion is, please don't perform bronchoscopy with if you have a peripheral lesion and if you don't have a guidance system. Among the guidance system, fluoroscopy has been utilized for many years and is still the most used guidance system worldwide. But the sensitivity of fluoroscopic guidance is not optimal Meta-analysis show that the sensitivity of fluoroscopic guidance is 78%, but you can see that we have paper that demonstrate a very low sensitivity, 36%. And the reason of this heterogeneity is that the sensitivity is influenced by a lot of criteria, a lot of factors, like the first one is the size of the lesion. If the size of the lesion is less than 2 centimeters, you see that the sensitivity of the fluoroscopic approach drop out to very low value of 33.58%. So sensitivity is influenced, greatly influenced by the lesion size. So for this reason, in the last year, a lot of new guidance systems have been proposed. EBUS mini probe, electromagnetic navigation systems, virtual bronchoscopy, transparenchymal nodule assess, and in the last year, the Combine CT that can be visualize also very small lesion in real time. But what is the problem? Alex Rodsman is there in the room. I saw him before. Very nice presentation. And we wrote together an editorial on respiration, and the title was Dancing in the Dark. And in this editorial, we focalize the fact that even if the new guidance system have been proposed, no randomized comparative studies that compare one guidance system to the other have been performed. This is the major problem of this clinical field. Sensitivity is influenced by the guidance system, probably yes, but we need a randomized study to be sure for this. Sensitivity is influenced by the sampling instruments. We have good evidence. We can use different sampling instruments for peripheral lesion, forceps biopsy, brush, curette, bronchoalveolar lavage, catheter, and also transbronchial needle. Well, in 1995, we published this study on chest. Well, and we demonstrated that transbronchial needle aspiration had a better sensitivity in comparison to forceps biopsy. The reason could be that the needle can penetrate into the lesion even if the lesion doesn't involve the mucosal surface. In case 1 and 2, the forceps biopsy maybe could have a good sensitivity, but in case 3, no. And also if the lesion is close to a bronchial spur, if we put the forceps, we can go in this direction or in this direction. If we put the needle, we can perforate the spur and penetrate into the lesion. And this has been demonstrated in this meta-analysis in which we participate. That was a systematic review evaluating the accuracy of transbronchial needle aspiration, comparing its diagnostic yield with transbronchial biopsy. And on 18 studies evaluated, we demonstrated that transbronchial needle aspiration showed a higher accuracy when compared to transbronchial biopsy, 60% versus 45%. So conventional transbronchial needle aspiration is a useful sampling technique for the diagnosis of peripheral lesion. Another factor is the relationship between airway and solitary pulmonary nodule. This is a classic and historical paper from David Nadick, a radiologist of New York, that demonstrated that if a bronchus sign, that means the presence of a bronchus leading to or contained within the nodule on the CT scan, if the bronchus sign is present, the sensitivity is greater in comparison to lesions with the negative bronchus sign. So the relationship, of course, affects sensitivity, and probably is the main factor that limits the sensitivity of the bronchial approach, because if we have no way to reach the lesion, whichever guidance system we are using, there is no way to reach the target. Well, in this context, what could be the role of ultrathin bronchoscope to improving sensitivity? For ultrathin bronchoscope, we mean bronchoscope with a diameter equal or less than 3 centimeters. It's better to use a thin bronchoscope. Thin is better in comparison to the normal scope. If we look at PubMed, there are a lot of papers on ultrathin bronchoscope, but I was really surprised because you can see here the studies performed with the ultrathin bronchoscope, and there is no use of the needle aspiration. Forceps biopsy was used in the majority of the study, brush, forceps plus brush. Just one study used the needle, TBNA. Even if needle, we have seen, is the better instrument for sampling peripheral lesion. And one study and needle was not systematically used. So in 2019, we had this technological improvement, the advent of an ultrathin bronchoscope, 3 millimeter, with a working channel of 1.7 millimeter. And through this working channel, it's possible to introduce such kind of needle that is very flexible needle, 20 millimeter length, and 21 gauge of diameter. And what is the rationale of using this technique? Look at this lesion. If we use a normal scope, probably we stop at this level. And if we introduce a needle to a normal bronchoscope, probably we were unable to sample this lesion that is located outside the airway. The mucosal surface is not involved in this lesion. With the use of ultrathin bronchoscope, we can arrive very proximal to this lesion. We can bend the tip of the scope, and we can insert the needle inside this lesion. To verify this possibility, I show you a series of clinical cases like in my previous talk. Look at this case. We have a nodule that is adjacent to the peripheral airway. If we put a normal scope, probably we were unable to arrive to this lesion, while with the ultrathin bronchoscope, we can approach this lesion, and bending the tip of the bronchoscope and using the needle, we were able to penetrate inside this lesion. And you can see here the fluoroscopic image of this real case, and the ultrathin bronchoscope that arrived close to the lesion, and bending the tip of the ultrathin bronchoscope, it's possible to approach and to sample the lesion. There is a paper on the literature recently published by a Japanese group. It was a randomized trial comparing an ultrathin bronchoscope 3 millimeters versus a thin bronchoscope 4 millimeter. And you can see here that on a large number of patients, 356 patients that were randomized, the sensitivity of the ultrathin bronchoscope was 70% in comparison to 58% of the thin bronchoscope 4 millimeter large. So the conclusion was that the use of 3 millimeter ultrathin bronchoscope resulted in a significantly higher diagnostic yield without affecting safety, because the adverse event were similar in both groups. Some cases of our experience, I will show you some peripheral nodule like this in the left upper lobe, and you can see that the ultrathin bronchoscope can arrive just adjacent to the nodule, and again in this lesion that is very similar in the left upper lobe. You can arrive to the lesion with the tip of the scope, and under fluoroscopic guidance, you can approach the lesion. You can use also radial mini probe to verify, because there are radial mini probe of 1.1 millimeter that is possible to insert to the working channel of the ultrateam bronchoscope to be safe that the lesion is centered. These cases were 2 cases of adenocarcinoma. Look at this lesion. This lesion is very close to the pleural and to the pericardium in the periphery of the lung. Is it possible to arrive to this lesion with the ultrateam bronchoscope? Yes, it's possible. Look at this. We arrived to this lesion with the ultrateam bronchoscope, and in this case, the diagnosis was hamartoma. These are 2 small lesion, peripheral small lesion of the middle lobe, very similar in the case number 4 and the case number 5. Look at the ultrateam bronchoscope inserted in the middle lobe that approach the lesion very closely. And you can see here the needle that performed the sample of this lesion that was an adenocarcinoma. And this very similar case, again, you can see here the ultrateam bronchoscope. These are 1 centimeter lesion. And in this case, the diagnosis was carcinoid. So you can see the importance to perform the histological diagnosis of 2 very similar lesions from the point of view of a CT scan that have a different treatment modality and different prognosis if we get the correct diagnosis before surgery. Look at this lesion. It's less than 1 centimeter, 0.8 millimeter, very close to the pericardium and in the periphery. Well, the approach again with the ultrateam bronchoscope was possible to reach the lesion and to sample the small nodule and to make a diagnosis of adenocarcinoma. Carcinoid, sorry, it was a carcinoid. These are other 2 cases of peripheral lesion of the right upper lobes. Well, you can see here the first one. You can visualize where we can arrive in the periphery of the lung with the ultrateam bronchoscope, and also in this case, the possibility to bend the flexible ultrateam bronchoscope to approach this lesion localized very close to the mediastinum. Both cases were adenocarcinoma. And you can see here the high number of neoplastic cells that are recovered using a needle. This is a very small lesion located very close to the descending aorta. Well, you can see here the ultrateam bronchoscope and the sampling of this small lesion under fluoroscopic guidance. We have a randomized study that is ongoing, comparing the conventional versus ultrateam bronchoscope. This is the study design. If we have a peripheral nodule less than 3 centimeters, we randomize, and under fluoroscopic guidance, sometimes with the help of EBUS mini probe, we approach the nodule with a standard bronchoscope and standard transbronchial needle aspiration, and with ultrateam bronchoscope and transbronchial needle aspiration. You can see here that we have a greater sensitivity using transbronchial needle aspiration with the ultrateam bronchoscope. And if ROSE is negative with the standard bronchoscope, we shift the procedure using ultrateam bronchoscope And you can see that we have 15% more of diagnosis using this technique. The study is not yet finished because we need 140 patients to get the statistical power, and the study is still ongoing, and we hope to have as soon as possible the results. So the use of an ultrathin bronchoscope with transbronchial needle aspiration could be a new way to improve diagnostic sensitivity of the transbronchial approach to peripheral lesion. And don't forget that ultrathin bronchoscope can be used with all the guidance system, with a combined CT, with the ultrasound mini probe, and also with fluoroscopy. If the results of our ongoing study will be positive, such kind of approach could be employed also with more advanced guidance system. So I think that I demonstrated you that thin is better. And if my clinical case are not enough to demonstrate that thin is better, I show you this picture. The first one was taken in 2017 and the other one in 2020. And this is myself after a diet of 1 year, and I can assure you that thin is better. Thank you very much for your attention.
Thank you very much, Professor Gasparini, for this informative talk and experience, and I congratulate you about the loss of weight and the belly. We hope see you very soon near in our country. Anybody needs to ask Professor Gasparini? Any question?
What's the role of CT guided biopsy?
One of our colleagues asked about the CT guided biopsy in peripheral lesion and if there is any comparative study comparing the use of ultrathin bronchoscopy with the CT guided.
No, this is the problem. There are no comparative studies, but the sensitivity of transbronchial approach to peripheral lesion with the use of ultrathin bronchoscope and the new guidance system is increasing. But comparing the literature and the old paper is still lower in comparison to percutaneous needle aspiration under CT guidance. The problem is that percutaneous needle aspiration that could have a sensitivity that is around 90% or 85–90% has a high incidence of pneumothorax. Yes. And pneumothorax is a complication that is easily manageable. It's possible to manage very easily pneumothorax, but in some kind of patient, like COPD patients, or for other reason, it could be very dangerous. And in any case, it can make longer the pathway to the diagnosis and the therapy. It can require hospitalization. In some case it requires chest drainage. So it's better to avoid the pneumothorax. And since the sensitivity of transbronchial approach is now with the new guidance system and with ultrathin bronchoscope very close to 80%, I think that we should first try the transbronchial approach for the safety of the patient. And in our practice, we perform percutaneous needle aspiration only if transbronchial approach failed.
Okay, thank you. Thank you very much. Professor Ayman, want to ask? Okay.
Thank you, Dr. Gasparini. I would like to ask about a little bit concerned with the variability. Can you hear me now, sir?
Yes, now yes, but I didn't hear the diagnosis, the question.
First of all, thank you for the very stimulating talk. I'm a little bit concerned about the manipulation of the ultra-thin bronchoscope, especially in places like the upper lobe. And do you introduce the needle beforehand, or you put it? I'm concerned with damage of the scope or decrease the angle. As you show us, there were very, very acute angle, and you went to the upper lobe. So practically, how do you find this?
Yes, this is a good question, because the risk, one of the major risks of this procedure is to damage the scope. I insert the needle not before the bronchoscopy. I insert the needle. I try first to reach the lesion. Then I retract a little bit the scope and I insert the needle. Be careful to insert the flexible needle with the tip of the needle inside the sheet. The needle is very flexible, but when I insert the needle, I a little bit keep the tip of the scope straight, just to avoid to insert the needle with the tip of the scope bended. And when I have the needle inserted, I bend the scope and I extract the needle just when the sheet of the needle is outside the scope.
Okay, thank you. Thank you very much. Now we are going to close this session.
Thank you very much, and my best wishes to all of you. I hope next time to be there.
Yes, next time, inshallah. Now coffee break. We are beyond of time. ربع ساعة ونتقابل تاني عشان نحاول ندخل في السكيدول تايم. شكرا.